Welcome to week 14 of Pharmacology for Vocational Nursing, part 1. This week, we're going to study antibiotics. It's chapter 38 and 39 in your textbook, and what you'll find is that there are more than one audio lectures here on the website. That's because this is pretty long chapters. We've got this class, and then we have several subclasses that we're going to chat about for a few minutes. So let's get started. So, of course, antibiotics, we want to talk a little bit before that about microbial infection. Remember, there are microbes everywhere. They're in the external environment and the internal environment. The difference being that the majority that are in the external environment are not our normal flora, and the majority in our internal environment are the normal flora. Not to say that a flora cannot become adapted or become a problem when you have an immune deficiency or you have immune compromise in some way. So our first defenses are those things that were naturally present, like intact skin, our gastric acid, the cilia that lines the respiratory tract, and our immune factors. We've been studying about the immune system, as well as our white blood cells, those T cells, B cells, and the cell-mediated immunity, as well as our humoral. So when we look at the microbes and we look at the bacterial morphology, this is important for understanding a little bit of how antibiotics work. So antimicrobials, you'll hear me call them antimicrobials as well as antibiotics. You may hear them referred to as anti-infectives as well. These are drugs that are designed cytotoxic. Their distinguishing feature is that they are relatively selective for particular pathogens rather than the host, right? We don't want to harm the host. We want to kill the pathogen. So when you look at different types of antibiotics, you'll find that they cover different bacterial morphologies. And the morphology is described by the shape. So we have the bacillus, we have the coccus, the vibrio, the spirochete. When you really think about this, it's not important that you remember these details as you're not doing prescribing, but it is important for you to remember that if an antibiotic is not, a patient's not responding to an antibiotic, that it could be that we have the wrong prescription for them in terms of the specificity of these drugs. Another major concern for this particular therapeutic class of drugs is that we have the emergence of resistance to the antibiotics. So the pathogens are developing a resistance. What doesn't kill it makes it stronger. So antimicrobials selectively will inhibit or kill based on their ability to stop the replication of the pathogen. They interfere with the phase of the cell physiology that's required by the pathogen, and thus it can't replicate or it dies. They're typically classified and subclassified according to mechanism of action, chemical structure, and the spectrum of activity against a particular organism. So, excuse me. When we look at these structures, we also look at them in terms of whether they are gram-positive or gram-negative. You may have already done this in your Bio 8 class, or you may not have gotten there yet, but the reason that we care about the gram-positive or gram-negative status is that that is an indication of how the organism is built. And it helps the provider, the clinician, to move to the decision of which antibiotic they're going to order for your patient. So gram stain is this laboratory test that's used to divide these bacteria into these two groups. Gram-positive bacteria retain the staining of the dye, and so they appear a deep violet color on the microscope, under the microscope slide. And then the gram-negative bacteria don't retain the dye, and so they appear red on the slide. If you look, you'll see that this peptidoglycan glycan layer, they have a more fatty membrane on the gram-positive, whereas the gram-negative doesn't have the same type of membrane, right? So as a result, when we think of lipophilic versus lipophobic, we know that many of the antibiotics exert their effect by acting on this cell wall. And when they do this, when they act on this cell wall, they're more receptive if it's made to be lipophilic or lipophobic. Now, remember that anaerobes are the organisms that can grow without oxygen. So that particular characteristic allows them to grow in necrotic tissue and the poorly aerated portions of the respiratory tract. The mycobacteria have a very tough cell wall and they're very hard to kill. Whereas the yeast are gram-positive and rickettsia are gram-negative. So I'm sure you've remembered your chain of infection, right? But let's talk for a minute about origin, sites of origin. So there are community-associated infections. This is a infection that's acquired by a person who's not been hospitalized or had a medical procedure in the last year, whereas the healthcare-associated infection is the patient who has contracted this either in the hospital or institutional setting. It wasn't present or incubating in the patient when they were admitted to the facility. Frequently, these are more difficult to treat because the causative microorganism is already often drug resistant and also the most virulent strains. It occurs in about 10% of our hospitalized patients, and our most common healthcare-associated infection is MRSA, methicillin-resistant Staphylococcus aureus. You'll previously have probably heard these referred to as nosocomial infections, and you'll sometimes hear older nurses and providers refer to them as nosocomial. Understand that they're now called healthcare-associated infections. How do we prevent infection? How do we prevent particularly healthcare-associated infections? Well, hand washing, right? And hand washing. Also antiseptics and disinfectants and hand washing. Our disinfectants, remember, kill the organism. We only use disinfectants on non-living objects. So an example of this would be our wipes, with which we wipe down our equipment. In the clinical setting, we always wear gloves because they're not designed to be applied to living tissue. Whereas our antiseptics are designed to be applied exclusively to living tissue. They generally only inhibit the growth of microorganisms, but doesn't necessarily kill them. An example that you may have heard in the past is a soap called Hibiclens, right? So it inhibits the growth of microorganisms. Frequently, patients are told to shower in that prior to surgical procedures. Doesn't disinfect, but it is an antiseptic. So our antibiotics, these are medications that we use to treat bacterial infections. Remember, you'll hear them referred to as antimicrobials and anti-infectives. They are ideally started after we have, if we are able to culture, after we have collected a culture to identify the causative organism and the potential antibiotic susceptibilities. Now, that being said, I think it's important that you remember that infections are the most common reasons for primary care visits. And so respiratory tract infections are the most common, with upper respiratory bronchitis, pneumonia, chronic sinusitis, acute pharyngitis, and in children, otitis media, or ear infections. Other infections that are commonly seen in primary care are urinary tract infections and skin infections like cellulitis or infected acne. So when you think of the number of prescriptions, it's important to remember that not all of these can be cultured. That's ideal, but it's not realistic. So we do have some rules that we use when we prescribe. We can use what's called empiric therapy. And this is treatment of the infection before specific culture information has been reported or obtained. And this is good when we have an infection and we have a pretty good idea of what it is because a lot of people have had it, or we know that there's an outbreak, or the assessment reveals that this is what it acts like. Then we can have definitive therapy, where we've given antibiotic therapy that's specifically tailored to treat an organism that's identified with cultures. Sometimes we will start with empiric therapy. We'll do a culture, start the empiric therapy, and then when the culture comes back, change the antibiotic because we find out that it's either gram-positive or gram-negative. So empiric therapy is usually done with what we call a broad-spectrum antibiotic. So when we think of spectrum, we can have broad spectrum. This is their spectrum of activity, and that refers to the range of the pathogenic organisms that are affected by that drug. So when we want a broad spectrum antibiotic, we give that. Then when the culture comes back, we will go to a narrow spectrum. Now, narrow spectrum antibiotics act on a single organisms or a few groups of organisms. So they're very specific. And it's ideal that we can get more specific. It doesn't always happen though, because we don't culture everything. That's not realistic, as I said earlier. The narrow spectrum antibiotics then are very focused. Our tetracyclines have the broadest antibacterial spectrum of all the classes of antibiotics. And so they bind reversibly to the 30S and 50F subunits of the bacterial ribosome. And so they inhibit protein synthesis. So because of that, they have this really broad spectrum. Our narrow spectrum antibiotics, these are very specific. Now, when we look at antibiotic therapy, an important thing to remember is that fungi have more rigid cell walls than bacteria, so they are actually resistant to antibiotics. We use drugs to treat systemic fungal infections, like you will have heard of these drugs. They end in azole, the azole antifungals. You may hear also of the use of amphotericin B, capsifungin. These interfere with the critical components that are the normal physiology of fungi, but antibiotics will not affect fungi. Then we have our prophylactic therapy. Our prophylactic therapy is treatment with antibiotic to prevent an infection. So an example of when we would use this is when we are going to do surgery. We're going to give antibiotic or intra-abdominal surgery. They may get an IV antibiotic right before they go into surgery. We also will sometimes give it after trauma if there's been an open wound, because we don't see the infection yet, but there has been exposure to multiple pathogens. So it's prophylactic. So what do we watch for and monitor in our patients? Well, we're going to look for a therapeutic response. We hope to see that there's a decrease in the specific signs and symptoms of the infection. The fever's gone down, the white blood cell count is going down, there's less redness, inflammation, drainage, and pain. There could be a subtherapeutic response, which means that the signs and symptoms of the infection did not improve. There are other things that we need to consider with antibiotic therapy monitoring, such as I said earlier, the superbugs or the resistant bugs. They're resistant to the drugs. That's sometimes referred to as a super infection. So, for example, bacteria like the Staphylococcus strain are resistant if their growth is not halted by that maximal level of an antibiotic being tolerated by the host. So they develop into a more virulent strain, and they can have such things occur like spontaneous DNA mutations. And the main characteristics or the main mechanisms of resistance are that you get then a lower permeability of the antibiotic through that cell wall. For example, they may build up a thing called beta-lactamase.